so much for attending today's guest speaker talk. And we are very honored to have Dr. Erin Ogletree to join us today. Dr. Ogletree is a scientific program manager at National Institute on Minority Health and Health Disparities. His work focuses broadly on the causes and consequences of poor health in older adulthood. He's interested in both pharmacological and non-pharmacological interventions aimed at reducing health disparities and improving quality of life. And thank you so much. We're very excited about your talk, and let's get started.
Thank you so much. All right, so now the challenge. Will my technology work for this? So let's do screen run. All right, and then we'll start the presentation. Let's see. And then I need to switch display and then move this out of the way. Okay, so hopefully you can see my slides okay and everyone can hear me okay.
Yeah, we're all good.
Very good. Thank you so much. All right, so today, well, thank you very much for that introduction. I really appreciate the opportunity to talk about our resource, which is HDPulse. It is an ecosystem of minority health and health disparities resources. This resource was developed as part of the National Institute on Minority Health and Health Disparities, aims to develop resources to help community members, policymakers, and researchers better understand and improve minority health and health disparities. As already noted, I am Erin Ogletree, and I am presenting today on behalf of myself and my collaborators, Dr. Antoinette Percy-Lari and Dr. Tilda Farhat. Together, we work in the Office of Science Policy, Planning, Evaluation, and Reporting within the NIMHD. And so right before I get started, thank you for that introduction. So just so folks are aware of my background, I'm a quantitative researcher, but a trained gerontologist. And my research just really broadly focuses on minority health and aging. And so today, what we're going to be talking about, here's a brief overview. I'll provide a background of the resource and of our institute so you can understand where it came from and how it fits in with our purposes and our strategic plan goals. I will provide an introduction to the HDPulse resource itself. We will do an in-depth exploration of the data portal, accompanied by a brief demo of the data portal, and then I will introduce the interventions portal. And then at the end of this talk, there will be time for a Q&A. So if you can just hold your questions until the end, that would be much appreciated. And for folks who haven't had a chance to check out the portal, I've included a link here, and we also have a link included on the last slide. So moving right along. So a little bit of a background. NIMHD recognizes health disparities as health differences that adversely affect socially disadvantaged populations based on one or more health outcomes. And so given this focus, HDPulse was developed as a resource specifically for the purpose of exploring and understanding minority health and health disparities using population-level health data. Now, NIMHD and HDPulse have a unique focus on populations with health disparities. And populations with health disparities, for us, are grouped into 4 groups. So the first would be racial and ethnic minorities, and that would include American Indian or Alaska Natives, Asian populations, Black or Hispanic, or Black or African American populations, Hispanic and Latinos, and then Native Hawaiian or other Pacific Islanders. So racial and ethnic minorities are our first population with health disparities that we focus on and prioritize in our research. In addition, we also focus on individuals who have low socioeconomic status, those living in rural, underserved areas, and individuals who are sexual and gender minorities. And in the pictures down here, we just have representations that we focus on to sort of help demonstrate how HDPulse is unique from other resources in its focus specifically on minority health and health disparities. So what is HDPulse? We now know why it's been developed and who it focuses on, but what is it? So HDPulse provides access to data and resources that can be leveraged to improve minority health and reduce health disparities. As demonstrated in this image to the right, HDPulse includes two complementary portals. The first is a data portal, which helps identify, quantify, and visualize health disparities using population level data available at either the national level or state level and county levels. In addition, we have the upcoming initiative, which is the interventions portal. This portal provides access to interventions that have successfully improved minority health or reduced health disparities as determined by evidence-based literature or evidence-informed initiatives. Excuse me. And so together, going back to this idea of an ecosystem, we do envision HDPulse as an ecosystem. You can use the data portal to find differences, to identify disparities, and to examine determinants. And in addition, you can also use the interventions portal to identify interventions that have been shown to effectively improve minority health or reduce health disparities that have been identified using the data portal. From there, what we would hope is that disparities within the community and populations of interest would be reduced after effectively finding differences, identifying targeted interventions, and implementing those in settings down to the community level. And so with this information in mind, we will move on to the HDPulse data portal. And so what we have presented here is HDPulse's data portal homepage. A few things that stick out here. Here on the left, you can see, we have rather largely displayed that you can view data on the county level or at a geographic level by state and across the US. You can also see in this red box, unique to HDPulse is that our data are organized using the socio-ecological framework. And so this work is also informed by a social determinants of health framework. And so in that way, HDPulse is a resource for not only learning about health disparities through a social determinants of health lens, but also teaching about health disparities. You see down here on the bottom right that you can explore the data using additional visualizations such as historical trends, 5-year rate changes, or comparison graphs. Now, one of the big questions that we get about HDPulse is, well, where do we get this? Where do we get all these data? And what are your data sources? How many are there? And so I've just included a few examples on the right to sort of depict the varying sources from which we gather our information and visualize these data through HDPulse. So we have data coming from the Behavioral Risk Factor Surveillance System, the Youth Behavioral Risk Factor Surveillance System, the National Vital Statistics, the American Community Survey is notable, small area health insurance data, and then of course, US cancer statistics. Importantly, and something to keep in mind during this presentation, and as you think about how you could use this resource in your work, is that HDPulse is constantly growing, it is constantly changing, and it is constantly improving in its capabilities, in the scope of the data that are included, and in the partnerships that we develop to access data that may not be widely available to other audiences. So what I would recommend and to keep in mind is that even if you don't feel like the resource HDPulse could be useful for your specific research right now, what I highly recommend is keeping an eye on it because it is expanding rapidly, and as quickly as we can, we are updating information and increasing its capability so that it can be of use to a wider range of audiences. And so what I've already captured and talked about a little bit is that data topics are organized by the NIMHD research framework. So here you can see a few of those domains, which include healthcare system, knowledge, attitudes, and behaviors, physical environment, and social, economic, and cultural environment, as well as outcomes. So you see that in addition to including cancer incidents, HDPulse also includes data on mortality, various causes of mortality. It includes information on daily functioning. It has prevalence information in there as well, and then information on life expectancy. Of course, these are just a few examples of data that you can expect to see under each of these domains. And something really important to probably touch down on here, and as evidence through usability testing of both the interventions portal and the data portal, is that users who regularly utilize HDPulse, they use it because they see it as a one-stop shop. You don't have to be an expert in data to get on HDPulse's website and start exploring statistical differences and outcomes using rate ratios, for example, and also comparing them to determinants that they may be associated with. And so given that we have curated these data from multiple different sources and include various capabilities in visualizing these various data topics, users report that this is great. This is a one-stop shop, and it takes the burden off of community members to need to have statistical expertise in these areas, because you can just come to the portal and start exploring right away without having to download the data yourself, curate the data, create visualizations, some of which are captured here. And so, as we've already noted, we have several visualizations, including interactive maps. There are tables that focus on rates and trends. Metro versus non-metro isn't in the data portal right now, but we do have historical trends, 5-year rate changes, and then various rate and trend comparisons by both diseases and by geographic areas. And so now is a good point to pause and go ahead and actually explore the data portal with you all. So I will stop sharing my slides. And instead, I will pull up the data portal. And so when you visit HDPulse's website, this is the first thing you see. You see that we have the data portal on the left, the interventions portal on the right, and it says coming soon. So the interventions portal, which we'll talk about a little bit in the second part of this presentation, focuses on interventions that have been shown to improve minority health and reduce health disparities. We are in a limited launch of the interventions portal, so it is available, but only to researchers who we've invited to test it out. And once they have submitted interventions and we have a sizable repository of interventions, then we plan to open it up to the public so that folks can start utilizing this database. We'll revisit that at the second part of this presentation, but I wanted to give that caveat now. Additionally included on this page are some definitions for how we define minority health at the NIMHD. What constitutes minority health research, and what are those minority health populations? So these are the various racial and ethnic groups that I noted before. And then we also have down here those populations with health disparities that I noted in the beginning of the presentation. So if we want to pivot over to the data portal, you can do that either by selecting the link on the banner here or hitting Explore the Data Portal. It takes you to the page that I already showed you. And so this is a live interactive map. Most of our maps are live and interactive, and we are in the process of switching to a new type of mapping program that will increase their capabilities and the user friendliness of the design as well. So be on the lookout for that. A little bit of exploring that we can do here about the HDPulse data portal. It gives you some information about how users can use this information. And we also have information on new data releases so that folks know what the most recent data are that are captured in our portal from where they originate, and all other information related to data sharing. If we're looking at health outcomes, we can see that the 3 that we have captured here include mortality, which includes various causes of mortality. We also have incidences for varying types of cancers. And then we have daily functioning, which is daily activity limitations due to mental or physical health difficulties. You can also just explore and see what data topics are included under healthcare system, for example, or knowledge, attitudes, and behaviors, physical environment, and social, economic, and cultural environment. So one of the things that we just added that I will just highlight here are preventable hospital stays. This is something that is really important because it signals to care that has been delayed or omitted. And so we've just added this within the past few months. And so similarly, we would have additional variables on utilization, hopefully related to cancer as well, built into this system. So now that I've given the introduction to the data portal homepage, how about we switch over to cancer-related mortality? And so I chose mortality, and we can see that the map that's visualized here focuses on all causes of death, which is captured here and here. You can see on the left, the navigation pane will allow you to choose what cause of death you want to focus on. We're going to focus on cancer. You can choose the statistic that you want to view. So you can look at age-adjusted rates, or more importantly, you can look at rate ratios, which are a statistical measure of disparities, to understand how a focal population differs from the referent population. And it is important to note here that we currently use white populations as the referent population, but we are exploring other ways of visualizing disparities using rate ratios. There's one that we are considering called summary rate ratios, and it uses the group with the best health outcomes present in the data as the referent population. So here what we see is cancer-related mortality. These are just age-adjusted rates for all races, all sexes, and all ages from 2015 to 2019. If you're interested in just looking at rate ratios, you can generate that map. And we see here areas where the rate ratios for cancer-related mortality are worse for Black populations as compared to their white counterparts. But looking at the age-adjusted rates, you can just see where, so right now it's focused on Black populations, but we can switch back to all races. And you can see where the highest rates of cancer related mortality across the US are, regardless of racial or ethnic minority group affiliation. So, one of the key points that we've highlighted about HDPulse is its particular focus on identifying differences between racial or ethnic groups. And so you can view information like this by race or ethnicity. So here's what the age-adjusted rates look like for Black Americans, and then here's what age-adjusted rates would look like for Asian Americans and Pacific Islanders. We also have the table view, so you can sort based on age-adjusted death rates for cancer-related mortality, or you can sort based on the rate ratio of the focal population group that you specified in the list box here to the left as compared to whites. And so if we're interested in seeing, for example, where Asian American and Pacific Islanders have the highest, have the greatest disparities in terms of rate ratios as compared to white, we could just sort the table based on that information. And we see that rate ratio is a 1.05, and that is in the District of Columbia. Now, another feature that I am specifically partial to as a gerontologist and as someone who takes a life course approach, I'm very interested in historical trends over time. And so what we see here is, let's go ahead and map the historical trends in cancer-related mortality for white populations. So we see those rates from 2000 to 2019. In addition, we can go ahead and plot them for Black Americans. We can go ahead and plot them for American Indians or Alaskan Natives. And we can plot for other population groups as well. And so this gives you a sense of how the cancer-related mortality differs over time for varying racial or ethnic groups. What you can also look at is intergroup differences. And so if you wanted to specifically look at how rates of cancer for one population in one state compare to rates of cancer-related mortality for that same population in another state, which could highlight state-level differences in cancer prevention and screening and policy, perhaps. So let's see. Let's look at cancer-related mortality among Black residents in Alabama first. If it wants to load for us. And so let's add another line. So this is cancer-related mortality for Black Alabama residents. Let's see how they compare to Georgia residents. So we'll add a line for that as well. Interesting. We see that the rates for Black residents in Georgia are lower than the rates of cancer-related mortality for Black residents in Alabama. You can also stratify additionally by sex, male or female, or by age groups if you are interested in additional within group differences. So are there differences in cancer-related mortality for Black women who are above a certain age and below a certain age? We also have here the 5-year rate changes in mortality. And so this is specific. It keeps it, for the most part, the data portal keeps your list box selections as you click across the different data visualization capabilities. And so we see here, we're looking at the 5-year rate changes to determine whether they're rising or falling and whether that is significant as compared to other causes of death. So we see that cancer has a negative 1.8% year rate change, and that is significant, as indicated by, well, I would call this a pound sign, but I think folks refer to this now as a hashtag. But you can see that cancer is falling significantly. But if we're looking across Black residents in Alabama, you see that homicide and legal intervention is the cause of mortality with the highest increase, and it is significant at 8.3% a year. And so this is just one way in which you can see how cancer-related mortality compares to other causes of mortality across different geographic locations and across different groups. Similarly, we can look at the rate trend comparison to understand how states and counties differ in terms of their trends for cancer-related mortality. So in this rate trend comparison, we see here, for example, that Limestone County in Alabama has a cancer-related mortality rate that is rising and similar to the overall US rate. And so for a policymaker living in Alabama who's interested in identifying counties where there are rising rates of cancer-related mortality, this would be a good way to determine that. Similarly, if you were interested in looking at counties or states that are above the US rate, regardless of what their trend is. So are they doing better as compared to the US or worse? You can see that here. So we see that the rate is stable, but it's still above the US rate. Similarly, for those in the falling trend, we see that the rate is falling. So this could signal to effective screening and intervention activities within these counties, but the rate is still above the US rate. And so a few other things, because we won't revisit the HDPulse website for the remainder of this presentation. If you navigate to the interventions portal, it provides you a little bit of information about what the interventions portal is. We have some important information under About. Of course, we have different data releases, we have data revisions captured here, and then there's a whole host of other resources that I can show a little bit later. And so now that I've provided just this quick overview of the HDPulse data portal, what I want to show are some key examples related to cancer and how this can be used for cancer-related research. And so I will go back to resharing my slides. And I will change the display again. Okay, so as I shared, in addition to the brief demo, I'm going to go through a couple examples to demonstrate how HDPulse can be used to understand disparities in cancer and correlates of cancer. What we presented here is the geographic distribution of breast cancer incidence across US states for various racial and ethnic groups. This example highlights how various populations have varying representation across the US. I think for most of you, if you have a background in population research, you know that some populations just are not reflected in some states and counties. And so you may find in generating estimates that values are either suppressed or that data are not available. And so an example is that here we see that breast cancer incidence rates for Black Americans across the US, we see that the data are suppressed in the upper Midwest, which, is not surprising. There's these states in the upper Midwest tend to have higher populations of individuals who are from tribal nations, and so data may be suppressed on that level. In addition, while these examples show that there's geographic diversity in breast cancer incidence rates across the US, depending on which racial or ethnic group you're interested in studying, we have white women, we have females who are Black, we have those who are American Indian or Alaskan Native, and then Asian and Pacific Islander. And so you can just see how looking at rates for each group will provide a different picture and can help inform targeted efforts for breast cancer prevention and intervention. In this next example, I've already shown 5-year rate changes, but I'm additionally showing how these can be utilized to focus on various dimensions of sociodemographics. And so here, what we're going to demonstrate is differences in race and ethnicity. And in the picture you have on your screen, we see that these are 5-year rate changes for cancer incidence for white populations. We see here that the cancer incidence with a rising significant trend is prostate cancer. Now, if we want to compare that to another population group to see how their cancer-related priorities may differ, in this image, we see what those types of cancers are that have the highest rates as well. And in this example, so this is Asian American and Pacific Islander, both sexes, all ages, we see that uterine cancer, prostate cancer, and breast cancer are all higher. They're rising, and 2 of them, uterine cancer and breast cancer, but not prostate cancer, are significantly different from 0 in their trend. And so in this way, HDPulse can be used to identify types of cancer or individual cancer sites that may be of a higher priority for one population group over another. So in this example, we're going to demonstrate how you can additionally stratify by sex and age. What we have here is a focus on Asian American and Pacific Islander females who are aged 60 to 64. And we see that those cancer sites with the greatest incidence include uterine, pancreas, esophagus, and kidney and renal pelvis. And these are rising, but only 2 of them are significantly different from 0, as demonstrated by the hash, including uterine cancer and pancreatic cancer. Now, comparing by sex and age, we can also see how Asian American Pacific Islanders who are men over the age of 65, so this gets back to that intergroup variability. We see that pancreatic cancer, brain cancer, and prostate cancer are all rising, but that they're not significantly different from 0. And so again, this just highlights one way in which these visualization capabilities can be used to identify differences for varying racial or ethnic groups, further stratified by sex or by age. In this third example, what we've had depicted here, and which I demonstrated briefly in the demo, are examining disparities using rate ratios. So in the image on the left, we see the rate disparities in cancer mortality as measured by rate ratios for Black Americans as compared to white across the US. We see that for the most part, in most states across the US, Black Americans tend to have a higher risk for cancer than their white counterparts. There are just a few states here in which the rates for white populations are lower, and that is, I believe that's Idaho and New Hampshire captured here. And to look a little bit more further, you can see that this data is also available down to a county level. Now, you may run into issues where there's suppressed data, especially for smaller population groups like tribal populations or Native Hawaiian and Pacific Islanders. They tend to have less representation across the US, so data may be suppressed or the rate ratio is not significant. But if I were, a policymaker in Georgia, seeing that there are some counties where the rate ratio for mortality is higher for Black populations as compared to white, that's where I would focus my cancer prevention and screening and intervention efforts. I probably would not focus efforts towards Black populations in these counties that are blue, in which the rates are worse for white populations. A little bit of information about the rate ratios if you're unfamiliar. If you see a rate ratio of 1.96, which this legend down here provides a nice range of rate ratios across the US for Black populations as compared to whites. This rate ratio of a 1.96 tells us that Black populations in the US have almost 2 times the risk of cancer-related mortality than their white counterparts, at least based on these data. And so in a third example, we're exploring visual associations between determinants and cancer-related outcomes. So this is another, as I've noted, novel component of HDPulse, is that it includes both determinants and outcomes. And so in this image on the left, we see cancer-related mortality by Virginia County for all races, all sexes. Circled here is where we have the highest concentration, visually the highest concentration of cancer-related mortality across Virginia counties. In addition, in this image on the right, we're looking at the percent uninsured in each county in Virginia. And so circled here, we also see that there is a bit of a concentration here, whereas counties that have higher rates of uninsured population tend to also have higher rates of cancer-related mortality. So the research question for me, I don't have a background in cancer, so I would wager to say that individuals who have health insurance may be more likely to undergo cancer screening and therefore may be less likely to die due to cancer. And so this is just one way in which HDPulse and its visualization capabilities can help formulate research questions or ideas. And as I've already noted previously, these data are expanding. And so if there are specific determinants that you feel do not match up with determinants that would be important for cancer-related outcomes, you may be able to find those in the system in the future. And we are always, if you have feedback about what more we could include, you can always submit it through our contact form on the website or specifically to our email addresses, which are presented at the end of this presentation. Now, moving on to the data portal resources, I've already touched down on these a little bit. We're aware we have a dictionary of terms, which I've already sort of provided. We have an FAQ for frequently asked questions, as well as data use restrictions. You can download the data off of our website, and you can also download the visualizations that you create. And of course, you can always just do screenshots. But these resources are intended to help folks who may have an interest in research if what their interest in minority health and health disparities research cannot be answered by the data portal, then we also try to point folks in the direction of other resources that can help them for their research purposes. Now for the data portal, we have additional table and graph descriptions in case you're unsure about what each of these visualizations or tables is showing you. And, I think that this is more important for populations or for community representatives and stakeholders who may have less of a rigorous research background, but are still interested in using data to promote health equity in their communities. And so given that introduction to the HDPulse data portal, I would be remiss if I did not go into the interventions portal, because the interventions portal, along with HDPulse, is really one of the big things that makes it a novel resource. Important to note here is that we are in the process of identifying interventions to populate the data portal, and we are doing those across different disease disorders and conditions. So we are actively searching for cancer interventions that have been shown to improve minority health or reduce health disparities, in addition to also looking for interventions related to any of those data topics that you saw in the data portal. And so while you cannot see the data portal live on HDPulse's website, this is a snapshot of the development portal, which has a limited release currently to only invited investigators. See here is that, again, it is a repository of interventions. So currently, it looks like we have 24 total interventions populated. And on this screen, you can see some identifying information, related to these interventions. So, the title of this one, Promoting Hepatitis B Vaccination in Vietnamese American Children. We can see that the disease, disorder, or condition focus is hepatitis B. We can see that the age group included is youth and adults. We can see that the community setting is also urban or inner city. And there are additional pieces of information that you can filter by, study characteristics or identifying information, which are captured here and further expanded here. So it might be a little bit hard to see, but you can see that we have 4 interventions included in the interventions portal already that are related to cancer or malignant neoplasms. We have populations with health disparities, including those that we mentioned earlier. We have a range of ages available, gender identity and sexual orientations, geographic location, community type, and determinants reported. So this is intended to be a flexible resource that allows users to go in and find actionable interventions that can be used to reduce those disparities that they found in the data portal. And so we're working on complementarity between the 2 portals to ensure that the interventions populated in the portal are adequately represent the data topics that we have within the data portal as well. So what comes with interventions? Each intervention is accompanied by supporting materials, which can include publications of intervention findings, any outreach or recruitment materials that the study investigators develop as a part of the intervention. So this should remove some barriers to increasing the implementation of these interventions. They also have publicity materials such as posters, flyers, and press releases used to advertise or to recruit for the intervention. Participant education tools, if those were included, brochures, fact sheets, and pamphlets that can be replicated or modified for various audiences, instruments or measurement tools, especially if they were developed as a part of the intervention study, and then contact information for intervention developers in case HDPulse users are interested in reaching out to the developers themselves to ask more questions. And so again, this goes back to HDPulse being a one-stop shop. You don't have to go to PubMed, look for the publications. You don't have to go to their website, the intervention developers' websites, to find recruitment materials or to identify the instruments or the measurement tools or to find their contact information. The goal of HDPulse is to put this information at your fingertips, at the fingertips of all stakeholders, so that they can have actionable tools to improve minority health and reduce health disparities. And as we've already noted, the key benefits of the interventions portal include increased accessibility to interventions and anything related to adopting an intervention. We also have increased community engagement in that researchers can develop, implement, or evaluate interventions in collaboration with community partners. And HDPulse is consumer friendly, and we are regularly undergoing usability testing to make sure that the data portal specifically is usable for stakeholders and users who may not have statistical expertise or background. The interventions portal is also a good resource for program planners and policymakers. I think that ideally we would have this great, massive intervention repository that captures, all state-of-the-art interventions. I don't think that's realistic, but it could at least be a good starting point for helping stakeholders get moving on interventions that can be used within their communities. It's also a resource for researchers to easily find interventions that have been shown to improve minority health and health disparities. And it also can help advance dissemination and implementation research. We know that there is a gap between the development of interventions and their uptake in community settings. And the goal of HDPulse, the interventions portal specifically, is to sort of speed up that gap in time, that lag between when effective interventions are developed and when they are employed at a larger level across the US and within communities. And so in these next few slides, I just want to give folks a little bit of an idea of the distribution of interventions that we've already identified for inclusion in the data portal, as well as what populations with health disparities they focus on and what the health conditions are of the interventions that we've identified. So I won't spend too much time here, but we see that the majority of our interventions have been specific to African American or Black populations. We see that the second most common would be those for individuals with low SES, followed by Hispanic or Latino populations. One thing to note that I forgot to mention about the data portal is that one of the big capabilities that we're having developed currently are additional capabilities for stratification by rurality. So in addition at looking at populations by race or ethnicity, sex, and age, you will also be able to look at it by rurality. Are there differences in cancer outcomes for Georgia counties that are rural versus non-rural, for example? And do they differ based on race or ethnicity? As far as the distribution of interventions, we see that the most common health condition that has been included so far in interventions that we've identified is metabolic diseases, but you see that we have already identified 6 interventions for inclusion that were specific to cancer. And so I hope by now I have done a good job in showing how finding differences within the data portal is complemented by interventions that can be used to help ameliorate those differences for the purposes of advancing health equity via improving minority health and reducing health disparities. And so to summarize a bit of what I presented today, I do want to note that we have undertaken and are working on publishing a pretty extensive analysis of data resources available for the purposes of exploring and understanding minority health and health disparities. And what we can say is that HDPulse is the only resource that is uniquely positioned to simultaneously address the following: data stratification by multiple sociodemographic domains. So this is done in a pursuit to advance intersectionality, especially in quantitative research. It's very limited in quantitative research, but folks are trying to advance this approach to understanding racial and ethnic minority populations. We also know that HDPulse is unique in that it has a wide range of determinants along the socio-ecological framework, and it's paired with outcomes, which is really important because you can see the relationship between determinants and outcomes. The information presented is fully accessible to the public. So there is no paywall to access this resource. There are other resources available that you have to pay for that don't do all of these things. And so HDPulse is unique in that way, in reducing the barrier needed, because we know that many community agencies may not have the funds to have institutional licenses to other programs. And so that's why HDPulse is so important. It's also lay audience friendly. I shared that we're constantly working to make it more lay audience friendly. And it focuses again on the continuum: identify disparities, examine determinants, and find interventions. And then finally, back to the question that most folks have is, how is this different from X? Well, the focus is primarily on health disparities. It includes a statistical measure of disparity, which is exceedingly rare, and is not focused on just one disease, disorder, or condition. So whereas other websites, for example, may focus on end-stage renal disease or cancer or HIV, HDPulse includes many of these. We're working on end-stage renal disease by developing a partnership with the United States Renal Data System, and we are also working to access HIV incidence data from the CDC. And so, as noted, there's always more to come, but this should give you a snapshot of what makes HDPulse unique and how it can be used. And so this brings us now to the Q&A portion of my presentation. So I will switch over so that you can see my email address. the email address of my collaborator, Dr. Antoinette Percy-Lari, and access the link to the HDPulse website. And I will stop sharing my screen as well.
Right, thank you so much. This is so impressive. I see a hand raised here. Let's just go ahead with Lan. Would you like to ask a question? I'm going to read some other questions from the chat box later.
Sure, I can start. Thank you for the presentation. My name is Lan. I am an assistant professor at NYU Grossman School of Medicine. So thank you for the presentation. The data portal seems very user-friendly. I did have a question of whether there are plans to disaggregate Asian from Pacific Islander. So as you had mentioned, OMB Directive 15 separates the two racial groups. And I checked through most of the outcomes and it seems to combine Asian Pacific Islander together. So are there plans to expand it to disaggregate the two racial groups, but also to include other ethnic groups?
So yes, and we're currently in conversation for that regarding this very issue. One of the things that we ran into recently is the exact point that you've made, that they're grouped together, Asian and Pacific Islander, and how further disaggregating those groups could better highlight disparities between subgroups. And so we are in those conversations. The main issue that we run into is that we are limited in displaying data based on how they're aggregate from the various data sources. So I do believe that ACS, and I'm sure that someone could correct me if I'm wrong, I do believe the American Cancer, or not the American Cancer Society, the American Community Survey differentiates between Asian and Pacific Islander, but a lot of the data that we get are from SEERStat, and those are calculated for our website, and it groups them together. And so we are in a conversation with our statisticians and with our partners about how we can disaggregate groups further in a way that's not going to lead to so much data suppression, because that would be the other issue. When we disaggregate these groups, we have a smaller denominator to select from. And so it could be that disaggregating these groups, at least for the purposes in the data portal, maybe it doesn't highlight any new novel information, but instead obscures further by just showing you a bunch of suppressed data. So that's the challenge that we face with trying to disaggregate various populations with health disparities and racial and ethnic subgroups further. But it's a great question, and it's one that we are really struggling with.
Yeah, thank you for that. I guess a recommendation is perhaps if ethnic group data aren't available, to still disaggregate the two racial groups, even if data are suppressed. Because I think otherwise, like the Native Hawaiian Pacific Islander outcomes might be invisibilized based on the large Asian American sample. Thank you.
Yeah, and that's a great point. Thank you for that.
All right, Aaron, I'm going to read a couple more questions from the chat box to you.
Okay.
One is from Russell that says, if there are data on social determinants such as food and housing insecurity, social deprivation indices, or if there's any plan for adding these data in the future.
So yes and yes. We have talked about including various indices. I think the challenge, so the econometrician on our team is really against including these indices. I would love to include something like the Social Vulnerability Index, but there are issues inherent to developing those, and they may be less interpretable to lay audiences. And so we don't want to facilitate indices that aren't easily understood by a wide range of audiences, and that could perhaps be misused as an unintended consequence of including them. And so we do have an eye on various indices, especially something like the Social Deprivation Index. But generally what we would say is, if there's already a resource that's doing it better, so the Social Deprivation Index, there's an entire portal that you can go in and explore related to that. But we do have information in the data portal related to food choices. I don't think access to healthy foods is there. Financial stability, I believe, through looking at poverty level, through looking at median family income and median home income. Yeah, those are the only ones that I could speak to in this moment. But as I noted, we are always trying to expand these, especially as they relate to social determinants of health. So thank you for that question.
All right, great, thank you. So we know that the intervention portal is being developed. So so that question is good. There's a question about, will this align with our tips and EBCCP on NCI's website? I actually am not familiar with the abbreviations. Pajaka, do you want to elaborate on the question?
Yeah, this is the Research Tested Interventions Program website on NCI, which just recently converted to the evidence-based cancer control programs. It's similarly a repository of interventions that are more specific to cancer prevention and control. And I was wondering, because I feel like there's been decades of thought put into some of that intervention, the way interventions are displayed, and they do match with what was presented today. So I think there is some, and I see Antoinette as your collaborator.
Yeah,
so.
Yeah.
but I was going to say I can speak to that. I'm actually leading the intervention, the development of the interventions portal. So we did consult with NCI before developing the portal. So they do have a hand in this. We've also consulted with them about the data portal, speaking to NCI statisticians and geospatial specialists. So we're all, in collaboration together. And we will continue to have conversations with NCI. But I did want to mention that the difference with this interventions portal is that we are focused on various diseases, and our interventions are specific to only populations with health disparities, which is one of the big differences. Only the minority populations and populations with health disparities, and then the site is also arranged differently, filtered differently. So that's those are some of the differences.
Yeah.
Thanks, Antoinette.
You're welcome.
Yeah, so we're very fortunate to have Antoinette with us because she's, involved with NCI on all this work. So we've been able to pull all her expertise into HDPulse, and now, we all interact and work together so that both of these resources can be improved, but just in different ways and for different purposes.
All right, one more question here. Is there any data on primary language, and is there data for specific AAPI subgroups?
I don't think we have information on primary language spoken at home. That is on our list. As far as specific AAPI subgroups, we do not have that information in the data portal. And we would just, the same issue that I noted before is that we come up against this. We know that there is, I talk about this variability within racial groups and across racial or ethnic subgroups. We know that it's there, but we walk this fine line between how we know we should categorize these so that these groups adequately represent their constituents. But there's also the methodological component related to data availability and whether we'll be able to visualize those data. So we would love to do that, but we don't have it now. And
all right, one last question is again from Lan on, for the intervention portal, are there plans to include the distribution on education, language, or income from the intervention participants?
So that is a really good point. So I would say that in a study, for example, when we review these interventions, I don't think we capture education or language, but we do note if they are low socioeconomic status. And that is one of the filters that you can search by in the interventions portal. But I think that your note about education and about language are are well made, because that is important. I think as well, so I would have to think further, especially as we expand the number of interventions that we're reviewing for our portal, about, how, because we do it with the view of culturally tailored interventions. How can these be tailored to different audiences? And so if materials have been adapted in another language from their primary source, we would have that included in the examples. But as far as if it's there now, if it is, I don't know that we've made it a priority right now, but we definitely have low SES as an indicator.
Yeah, and I want to add that, yeah, this is something that I think is needed, but we can only, we input what's available, right? What researchers have provided or can provide to us. So some of these interventions are limited in what we would like offered. And I think, Aaron, you had pointed out that we have currently have low, limited number of SGM interventions and rural interventions. And these are things we want. We want to populate the interventions with, populate the portal with the types of interventions that is relevant and that our users will benefit from. But again, it's up to whether these interventions are available to us, and if researchers are willing to provide that to us to put on our portal. So I reach out to you all. If you have interventions that you're willing to share and would like, and we get your permission to showcase that on our portal, we are grateful. We will be grateful for that. So let us know.
Yeah.
Thank you.
All right, I think that's all the questions I see in the chat box. And by all these questions, Aaron, can see how exciting we are of seeing this portal and hear more about this. Is really incredible work. And we look forward to seeing the more development from the portal. And I just want to thank you again for telling us about the portal today and give us the introduction about it.
Of course. Thank you so much for having us. Thank you, Antoinette. And thank you everyone for your questions. This is great. And of course, we love advertising this because we want everyone to use it and benefit from it. So thank you so much.